So wonderful. Thank you all for joining us today. This is the final webinar in the 2020-2021 Topics in Brain Injury, Complex Issues in Vulnerable and At-Risk Populations. And today we will be hearing from Caitlin Synovec as she talks about system-level strategies and resources for brain injury in vulnerable and at-risk present populations. This webinar is hosted by the Center on Brain Injury Research and Training at the University of Oregon and is funded through the Administration for Community Living's Traumatic Brain Injury State Partnerships Program. My name is Megan Jones. I'm going to go ahead and put my email in the chat. If you have any questions or anything comes up, you need any technical assistance, please email me. I'll be checking that email throughout the presentation. So after the presentation is over, we'll have a few minutes for some Q&A. I will give a little bit of a heads up that to ensure the highest quality audio experience for you all, we pre-recorded the presentation and we'll have a live Q&A at the end. But I did want to let you know that the presentation is just about an hour, so the Q&A will be after the turn of the hour. And I also wanted to let you know to please put in your questions as they come up during the presentation so you don't forget about them by the end. And also Caitlin will be with us throughout the presentation, and so she'll be able to answer some of your questions throughout the presentation. And the chat function is enabled, so please feel free to interact with one another. But just for everyone's digital safety, I'd like to ask you to not click on any links from one another, just in case. And if you have any links to share with the group, if you want to go ahead and send them to the panelists, we'll check them for safety and appropriateness and then share them back out with the group. Okay, so without further ado, I'd like to go ahead and start our presentation. Thank you, everyone.
Hi, everyone, and welcome to today's session on systems-level strategies and resources for brain injury in vulnerable and at-risk populations. My name is Caitlin Synovec, and I am an occupational therapist currently working for the National Healthcare for the Homeless Council, and most of my practice has been working with individuals experiencing homelessness, especially addressing cognition and traumatic brain injury and other factors that impact people's ability to engage within their communities. So you might have seen me in a couple other previous webinars talking about specific accommodations and strategies, as well as brain injury screening. This webinar today is going to focus on system-level strategies and resources for people who've experienced brain injury in at-risk populations. So our previous webinars did a little bit more of a micro focus on specific actions to take. Today's webinar, our objectives are to look more at these systems level and population level issues. So our objectives for today are that we're going to identify populations vulnerable and at risk for brain injury in the US. We are also going to identify benefits of screening for brain injury within the organization, and also identifying strategies and accommodations that can be applied within organizations and systems to help address the needs of people with brain injury. So like I mentioned, there are a couple of other previous webinars. CBER actually has several webinars available on their website. Two that I'm going to build off of today. The first was screening for brain injury, and the second, accommodating brain injury. So I'm going to review some of the concepts from those two previous presentations here, linking them to organizational and systems level strategies, but I do recommend going back to look at those and watching those more closely if you're interested in some of the more specific details, especially regarding screening and accommodations for the individual person. So I want to take a moment to review social determinants of health and at-risk groups. So the definition that I'm using for social determinants of health today is the one developed by the Centers for Disease Control. And the CDC has identified social determinants of health as conditions in the environments in which people are born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health are the primary cause of health inequities across communities. And so the CDC identifies 5 key areas of social determinants of health in Healthy People 2020, which includes healthcare access and quality, education access and quality, social and community context, economic stability, and the neighborhood and the built environment. And we touched on these in the previous webinar a little bit, but we're going to talk more about sort of these, again, this population level impact of social determinants of health and why it's so important to think about social determinants of health alongside what might happen for somebody who's experienced a brain injury. And so there are some key populations, again, that are more vulnerable and at risk for experiencing a TBI. And these groups include adults experiencing homelessness, victims of domestic and interpersonal violence, adults who have been incarcerated or are engaged with the criminal justice system, adults living in poverty, underserved rural and frontier communities, and veterans who've been dishonorably discharged. So we know that there's a high rate of traumatic brain injury among veterans, but we also know that there's a significantly high rate of TBI among those who've been dishonorably discharged, which is important to consider because they don't have access to VA services and resources the same way that somebody who has been honorably discharged. I'm not going to go into depth about the specifics and the statistics of each of these populations. Again, that was in one of the previous webinars, but keeping these groups of people in mind as we think about who should be screening and why different organizations should be screening. And, really, if you're serving any of these populations, and likely if you're serving one of these, you're probably serving a couple, why screening might be so important to incorporate within your setting. So another review of TBI recovery, when a person has sustained a brain injury, 2 of the strongest predictors of social integration and positive outcomes after TBI are a person's social support and their education and cognitive reserve. And so cognitive reserve is the cognitive skills or cognitive capacity that a person might have had before injury. So when we're rebuilding those skills and strategies, we're aiming towards or working towards what the person might have had before the injury. And having a decreased level of education and cognitive skills prior to injury can certainly impact and generally doesn't positively impact recovery after TBI. And so we want to think about the crossover of these 2 events because social determinants of health disproportionately impact low income and individuals living in poverty. And these social and economic factors that happen and are part of people's experience can impact recovery post-TBI almost as much as the physiological factors that happen from the brain injury. This can impact somebody's ability to manage their healthcare needs and resume previous roles that they might have had before injury. Additionally, social determinants of health impact cognition, and it can exacerbate maybe some cognitive impacts that were caused by the traumatic brain injury. So looking a little bit more specifically, going back to what we know to be predictors of good recovery, we have the social and economic factors, again, impacting all of these different things. And if you have less of this in your life, and often people who are impacted by social determinants of health do, then that's going to impact our trajectory. I'm going to review briefly about cognition, although we're not going to get into details into it today. Again, that was in one of the previous webinars, but there's a lot of things that it can impact cognition in addition to the experience of traumatic brain injury. So there's all of these medical factors that can be co-occurring. Somebody maybe HIV, especially if it's more progressed, somebody who's actively using substances, certainly with a history of substance use as well. Mental illness and mental health symptoms, although these may not always impact somebody's cognition. If you're in an acute depressive episode or an acute psychotic episode, or your symptoms are more persistent, that's going to impact your cognition on top of anything else. Similarly, environmental conditions can really impact cognition. And I think a lot of us can relate to that, right? Especially thinking about the impact of living with COVID over this past year, people are talking about sort of that COVID brain fog, right? And that happens even if you weren't ill with COVID, but the chronic stress of living in this environment and situation has impacted our cognitive functionings. And that happens for anyone who's been under extreme and chronic stress, such as homelessness, in addition to all all the other factors of instability. If you don't have a safe place, stable place to stay, it's really hard to get a good night's sleep. Chronic sleep deprivation absolutely impacts how we function cognitively, in addition to any of these other factors here. So when we think about folks who fall into these vulnerable and at-risk categories and are impacted by multiple social determinants of health, there may be everything on the environmental list is impacting them, in addition to having a chronic condition or a mental health diagnosis and the experience of TBI. So that's a lot of things that are really affecting individuals and other people. And when we have undiagnosed and unidentified TBI, then we're not always addressing all of the causes, and it can impact a person's ability to engage effectively in services. Looking at that more social support side of things for traumatic brain injury recovery, there's evidence to show that even if for folks who do have social supports and social networks, these social networks tend to be smaller and are not as protective against stress and don't provide economic benefit. So people, and really this is because people who are impacted by social determinants of health, oftentimes their social networks are also impacted by social determinants of health. So if you're living in poverty, your neighbors or your family members or your friends may also be living in poverty. And so these, although they may be emotional support systems, can't necessarily offer the same thing that support systems who aren't in poverty may offer, such as a place to stay, ability to be a caregiver, even financial and economic support, whatever that might be. And that's really significant because a lot of times recovery from traumatic brain injury is framed around engaging with the caregivers. And we have to be careful of how much caregivers can do and how much they're able to offer, and be aware of that so that we can set families and individuals up with the right support to address these factors. Additionally, what we know of the impact of social determinants of health, housing instability, and decreased economic standing is associated with poor healthcare access and being uninsured. People who don't have health insurance or don't have the funds to pay for healthcare will postpone needed care. They're unable to get medications when they're prescribed, and often this leads to not being able to access preventative care or address something when maybe it's a minor issue, and waiting until it's a really serious issue, resulting in higher hospitalization rates. And so again, if there's a traumatic brain injury or maybe even multiple traumatic brain injuries, a person may not seek services unless it's severe, significant, or the person needs to call 911 because they can't afford the care and treatment that comes with that. For people impacted by social determinants of health and living in poverty, there are a significant number of barriers to care. Again, cost and lack of insurance coverage, but there are other things that prevent people from being able to get to healthcare as well. Not being able to take time off work, not having paid family leave or time leave, not having access to consistent and reliable transportation, not being able to access providers or have a place to receive mail or a phone to get reminder calls, information about upcoming appointments. People may have longer wait times. There may not be as many providers in their community that take their insurance, or we'll see people without health insurance. And sometimes these providers are really overwhelmed, which can really affect being able to get an appointment and get in contact with the doctor. Additionally, people report some more emotional factors as well, in that when they go, they feel stigmatized, they feel labeled, they feel discriminated against. And if you go somewhere and have that experience and feel like people aren't listening to you or aren't taking your concerns seriously, it's going to not motivate you to go back. And so sometimes people don't seek out healthcare because they don't have a provider that they have a good relationship with, that they feel like understands them and is going to address their concerns. So what do we do about all of this, especially to support people with a traumatic brain injury? In the previous webinars, we went over what it means to build an alliance and what that might look like, developing compensatory strategies and routines. And so today we're going to talk about developing a supportive environment. And again, that's thinking big in terms of our systems and what we do about it, as well as what do we do in our buildings to become more accessible. So starting with some agency and organizational approaches to identify and address TBI. So again, we're thinking at a broader population level, right? We want to consider If we're serving groups that are more likely to be impacted by a history of TBI, how do we reach out to them? How do we engage them? How do we identify that and get appropriate services? In these groups, we know that traumatic brain injury is more likely to be undiagnosed. So not only do we have higher rates of traumatic brain injury, but we also have a higher rate of not getting a diagnosis and not seeking treatment. And what this means is we need to think about universal screening. We need to think about universal precautions to make care accessible. So how do we just make our services accessible regardless of what somebody might be presenting with? And it takes a level of advocacy, both within your organization, perhaps to make change, but also within your communities to develop resources that are going to engage folks and really meet their needs better. So the first thing to think about in terms of integrating screening for TBI, does my organization serve these at-risk populations? And again, I would likely say that somebody who's experiencing one of those kind of at-risk vulnerabilities is likely experiencing more than one. And also looking at your organization, an impetus for change is to look and see, are there things that are not working, right? Do we have a group of people that don't have as good of outcomes, aren't as successful, maybe initiate care but don't follow through on care? Is there something that we're missing in being able to reach these clients? And engage with your staff too, right? So, their staff may not be comfortable or feel like they have the tools or knowledge to really address what might be going on with somebody experiencing brain injury or cognitive impairment. They may want to, but may feel like, I don't know how to help this person. And that's really a big deal too, right? You want to empower staff. Staff want to feel like I can meet the needs of the people in front of me. So when you're integrating traumatic or screening for traumatic brain injury into your organization, there's some key things to think about, right? You want to think about who is it that's going to do the screening? Is it at initial intake? Is it a certain level of provider that's going to do it? Who do we want to start with, and so that we can do this consistently? And at what point of contact, right? Are we going to do a screening on anyone that might walk in the building for their first appointment? Or are we going to do a screening, once they've engaged with a mental health provider, with a case manager, with a primary care, whatever that role might be? And then once we've done the screen, where does it become integrated in the person's history and record, right? In order to have the benefits of doing the screen, having this knowledge, it needs to be somewhere where other providers can see it. It needs to be in a place where the results can be documented in case we're using it to access services. So, you might complete it on the paper form, but what happens next? And that process needs to be thought about and determined. And who needs to see the results? A lot of times when we're working with these more vulnerable or at-risk groups, people are engaged with care teams, multidisciplinary teams. And so who needs to know, and how does this information get incorporated into what they're doing? Additionally, need to determine if we have a positive screen, who adds the diagnosis to their history, to their record, to their problem list, who's responsible for doing that? And then once we've identified potentially somebody who has a positive screen, what are we going to do to coordinate care and to refer the person to the appropriate supports and resources? It's much easier and will be much more successful to integrate the screening into your organization if these questions are answered before you start doing it. Otherwise, you might have providers screening, but not really sure what to do next, and the information doesn't go anywhere, right? And if that happens, then we're not changing necessarily anything for the people that need services, except that we're identifying it. And identification is a great start, but it's helpful to think about what happens next. So what it could potentially look like, and this is not the only way to do it, right? But just to give an example, is that a client may complete the intake, then they're connected with a case manager. That case manager may complete the OSU TBI screen. And with a positive screen, the case manager then makes the connection to a primary care provider, whether that's in-house or another community organization. The primary care provider then follows up and completes a history and evaluation to determine impact of symptoms and potentially to develop a diagnosis, and entering that into the person's chart and problem list. And then finally, the PCP and the case manager work together to coordinate what types of referrals are needed and to support the person in being able to get those. I will say something about referrals. It's one thing to hand a person a card and say, you need to call this person to set up an appointment, versus doing a warm handoff and supporting the person in setting up the appointment, ensuring that there's transportation, even communicating with who they'll be seeing, just to discuss needs ahead of time, of course, with the person's consent. But there's a lot of steps that can be taken to make that transition to any sort of specialist even smoother and more successful. So I'm going to show an example of what this could potentially look like, with a real person, in terms of how this screening helped to support determining what services were needed and what the client engaged with. So we have Derek, who is a 32-year-old male who was seeking services at a federally qualified health center for people experiencing homelessness. His history was that he had been living independently until he was arrested as part of the city's policing practices, in which they swept buildings where there was suspected drug activity. He was incarcerated for 3 months before being released, as there was no evidence indicating he was ever involved in any drug-related activity. Unfortunately, during his incarceration, he sustained a severe TBI with a loss of consciousness lasting over 24 hours. He was treated medically following the injury for swelling in his brain, but received no other care. Once he was released, Derek attempted to stay at the city's local shelter, but ended up leaving as he could not tolerate the noise and activity level. He also reported he felt he couldn't control his anger and wanted to avoid any altercations or getting into fights. Derek's mom was a good support and lived nearby, but was in a subsidized housing unit for seniors. So despite that their close relationship and feeling really supportive, he was unable to stay there for more than 7 nights a month. So this scenario really highlights, right, some of these concepts developed at the beginning. One, Derek was a victim essentially of racist policing practices in his city. And unfortunately, part of that sustained this really significant TBI. And although they did treat it medically, because he was incarcerated, he was not given access to any other resources at his injury. And when he was released with, go out and go back and live your life. So he initially sought support at the shelter, but couldn't tolerate that environment because of his TBI. And then highlighting that social support piece, right? So again, he had a social support system, but the support system couldn't provide the level of support that he needed because of constraints of living in poverty and relying on subsidized housing. And there's a lot of rules about what people can and cannot do in those units. And so, it was sort of this choice for his mom of letting him stay there, but then also ultimately risking both of their ability to have a safe place. So they opted that he slept on the street and he would come to his mom's house to shower and help her out. And, he could leave his stuff there, leave his clothes there, but really didn't have another place to stay. So when Derek came to the clinic, to the FQHC, he identified needing several services. One is that he needed benefits of some sort, and income. He lacked income. He lacked a lot of his resources that he'd had before he was incarcerated. He also identified wanting help with his anger and needing to be able to remember things. He identified specifically with his memory frustration with not remembering to get to appointments, which were important, forgetting what he wanted to buy and what he was supposed to do next. So these are all the, sort of his presenting complaints when he accessed care at the FQHC. So some things to consider within your organization. If this person came to you seeking services, where would you start, right? What would you want to do? What services would you refer him to first? And what strategies could you use to address his concerns? So the first thing that happened was a TBI screening was administered, right? And so there was the identification that he did have this significant head injury. So there was a few things that happened. To address his concern about benefits and income, he was connected with case management to address his needs, regarding the need to have money and be able to support himself, and have housing. Additionally, he was then referred to a mental health therapist to address his concerns, and through that intake process identified not only the frustration and anger piece, but that he also had symptoms of depression and low mood, which were likely exacerbating some of that irritability he was experiencing. Because of that, he was also referred to psychiatry to assist with medication management to address some of these symptoms, in addition to seeing his mental health therapist. And then finally, he was referred to occupational therapy to address his memory and related functional concerns. Because he felt like he was being listened to and that his needs were being met, and he had all of these different supports in place now, he was able to really engage in long-term services, which helped him find an effective medication regimen to manage his symptoms. He was able to identify strategies to tolerate and engage in these community tasks, right? So part of it is, applying for benefits and going through the process of getting an ID and, applications for different services. It's hard and it's frustrating and it requires a lot of cognitive skills that these supports in place, such as his case management, as well as building the skills to manage frustration and focus, really supported his ability to get those tasks done. He also worked with OT to identify strategies to help track information, which was really important to increase his ability to get to these appointments, right? He's working with several different providers, several different appointments, as well as all the benefits related appointments, using Post-it notes for lists, right? Because he identified going to the store as one of his frustration points, and practicing self-cueing to remember small bits of information. But because of these comprehensive wraparound services that addressed all of these needs, which could be addressed because there was screening and a pathway in place for him to access appropriate services, there were so many positive long-term outcomes for him. He was able to work with case management to get all of his ID and go through the disability application process. He additionally was able to apply for housing and find a subsidized rental unit. Both of these things helped him move from homelessness back into his own apartment. With that transition, he worked with OT to rebuild independent living skills. So he'd been living independently before, but hadn't lived independently since the brain injury. And so he needed to identify some practice and skills to make that a successful transition into housing. With more stability, he was able to work with his mental health therapist also to address his longer term goals of reconnecting with his daughter, who he hadn't seen since before incarceration. And then with that, because he had all of this stability, he had improved frustration tolerance, he was around to be other people, he was able to focus more on these long-term goals, he was able to transition more to community-based supports and programs to address parenting skills and community relationships and positive friendships that he'd really been lacking while he was homeless. And then he eventually transitioned from the health center to a community PCP and behavioral health program. So the FQHC where he was at was specific for folks experiencing homelessness, which was set up to accommodate a lot of these supports and services more. But as he got better and as things improved, he transitioned to more community-based roles and could tolerate their environments much better. And so at this point, since then, he's been able to maintain housing for several years. He completed the benefits process and was awarded SSI, strongly in part due to the careful documentation regarding his brain injury. He remains a support for his mother. They obviously don't live together, but because he has more stability, he can help her out more, especially as she ages and addresses some of her own chronic health conditions. And he's been able to have his daughter over for weekly and consistent visits. So these are all a lot of really great things that happened for this individual, but the crux of this was identification of the brain injury and knowing what supports he needed in order to address a lot of those concerns that were stemming from that. So some ways to get started. It can seem a little bit daunting, right? There was a lot of complex services that Derek had available to him. And you don't necessarily start with all of that, right? If you're sort of building these resources and programs. And maybe you need organizational buy-in, right? So, not everybody at the top of the decision-making level sees the need for this. So there's a couple ways to go about this and get this started. One is to do a pilot project of screening. And this can be done in a couple of ways. One is that you can select one group of providers or clients who access services to determine a need. So one example might be all mental health providers in the setting are going to screen every individual they see over a 1 month period of time. And this will likely capture, most people who receive mental health services within that organization. It's not everyone, but it's a good glimpse especially because we know the relationship between mental health diagnoses and traumatic brain injury can be so high. Another way to go about pilot screening is that identify a specific period of time, and we're just going to screen everybody who comes through our doors for a week or a 2-week period. Again, and that gives a snapshot of what things are looking like and what the needs might be for my agency or organization. Again, if you're serving any of these groups, you're likely going to be able to find a high rate of traumatic brain injury, unfortunately. Additionally, you can do kind of a more robust needs assessment. In addition to the pilot screening, interview the providers who are working with clients, right? Do they identify that they need more awareness? Do they have concerns? What are the supports needed to help them be able to engage and work with these individuals better? Additionally, just doing an environmental scan. What resources are out there now for these populations? Who's addressing TBI? Is anybody else screening? What does it look like in our community? There may be some robust services in some place, but people don't know that they're there, or they're not necessarily serving a specific population. So looking at all of these different factors can kind of help you identify who needs to be doing it, how much, and when we need to be doing it when it comes to screening. So I'm going to show another case example here of doing a pilot screening and a pilot program within a federally qualified health center. Again, specifically serving people experiencing homelessness. And within this setting, comprehensive integrated services include primary care, behavioral health, substance use treatment, case management, supportive housing, occupational therapy, dental services, and benefits acquisition, including SOAR providers, as well as staff who were specifically to connect people with Medicaid and insurance services. So this one site offers a lot of wraparound services, right? But didn't have any formal or structured brain injury screening. So this pilot program specifically targeted the behavioral health and mental health providers, looking at both screening implementation among this group of people, as well as addressing the concerns of the providers in being able to meet the needs of their clients. So what we found from this, and I'm going to share a few results just to indicate what doing one pilot and one screening can do. So 172 clients were screened for a history of brain injury, primarily either by occupational therapy or by the mental health providers. And what they found, as you can see here, and this is using the framework of the OSU TBI, what we found is that 68% of clients screened positive for a worse brain injury where they had a loss of consciousness of some level. And it kind of breaks it down there. So 50 clients had 30 minutes or less, 40 clients had between 30 minutes and 24 hours, and 27 clients had a history of TBI that was 24 hours or longer. And so as you can see, the numbers are pretty high across the type of traumatic brain injury, but 117 that had at least some loss of consciousness is pretty significant. Interesting to compare that then to how many of these folks that were screened using the OSU TBI-ID actually had any sort of brain injury identified on their problem list before they were screened. And this is a huge difference in number. So only 12% of clients who'd been screened had any history of TBI documented in their chart. So 12% of clients had that in their problem list when there was not screening implemented. And when we did implement screening, 68% screened positive. That's a huge difference. Those with a higher loss of consciousness or longer loss of consciousness were more likely to have that identified in their problem list, which may not be surprising, just because if it's that significant of an injury, they may be more likely to report it to a primary care provider. But this, to me, this data by itself shows the importance of screening, right? That there is a huge gap between who has an experience of a brain injury and who's actually identified of that. So looking at what types of brain injuries people had, 55% of individuals had a brain injury that fell within two categories on the OSU TBI-ID. So that might be first before the age of 15, worst, which is a loss of consciousness, and again, showing that level that at least had some loss of consciousness, first, which is a traumatic brain injury before the age of 15, multiple traumatic brain injuries, within a close time together, and then other, which could be other factors having impacted the brain. And we'll see in a second with some comorbidities what that might look like here. And additionally, 77% of clients overall had at least 2, but up to 5 of the categories when they screened positive. And so when we're looking at co-occurring conditions, there is a high level of folks with affective disorder and substance use disorder. About 90 clients who screened positive for a brain injury had an affective disorder, and 100 who screened positive for brain injury had a substance use disorder. So this is the number, not the percentage, but that's out of 172 clients. So that is still a really high percentage of that. This may be skewed because it was the mental health providers that were doing the brain injury screening. And so people are likely engaging, they engage with mental health providers because of a symptomology, such as depression or substance use disorder. And that's maybe why this was so high. The important implication of this to me, though, is that people who've had a history of brain injury are going to have these co-occurring mental health conditions presenting for mental health therapy services. And that's why it's so important that mental health providers be able to screen for brain injury, because some of these symptoms may perhaps be coming from that history of brain injury, but it might be from something else too, right? Again, with people in social determinants of health, there might be a lot of other things going on, chronic trauma or stress, but that relationship is so high that we really need to be screening. So within this case, this pilot program, so we implemented screening among select mental health providers and occupational therapy. Additionally, providers were enabled to engage in a total of 8 sessions that occurred over a 6-month period to learn about cognitive deficits and cognitive areas that are impacted by brain injury, and thinking about what are some compensatory and adaptive strategies I can incorporate in my services, and also talking about what mental health models of care already support folks with brain injury. So sometimes it's not necessarily learning a whole bunch of new things, but thinking about which modalities that I know might be most effective. So there's 2 initial training sessions that included learning about screening and goal setting, and then the 6 didactic sessions covered different areas of cognition, using internal and external strategies, an opportunity for case application and discussion. And so what was found from this, again, this was a small group of providers and using a Likert scale, so certainly couldn't identify an effect size here. But as you can see, the darker blue is how folks rated themselves before they engaged in the training. And then the bluish green is how comfortable they were in assessing brain injury after the training. And what you can see is a big shift, right? Is that once people had the opportunity, and it was 1 to 2 sessions about screening for brain injury and using the tool, they felt much more comfortable screening for it. Second, the second piece of it, right, is that we've screened for brain injury. Now, so what? What do we do about this? And so again, we looked at how effective people felt that their interventions were prior to and then after the training. Again, the dark blue is representing prior to the training, which was somewhat mixed. And then after the training, most people felt like their interventions were more effective for people with brain injury. We didn't have an opportunity to, but it would really be interesting to dig through and sort of see the providers felt their interventions were more effective. What was the response of the client? Did the clients feel like their interventions were more effective? Did they feel more heard, or like their concerns were addressed more? And it would be interesting to see some of those long-term trajectories and outcome. I think we'd find a lot of stories similar to Derek there, in that people were able to get more appropriate supports and move further along the line towards what their goals were. So what are some implications, just from this one pilot program? It demonstrated a need for providers outside of the primary care provider to assess for history of brain injury, right? So the folks who had it in their problem list were the ones who were engaged with primary care as well, but people may not necessarily always engage with their primary care provider first, and certainly not as frequently. Mental health providers and services often occur 1 to 2 times a month, whereas a primary care provider visit maybe quarterly. And so more engagement, more touches, mental health providers have more access to people. And again, that high comorbidity of mental health disorders with a history of traumatic brain injury. And also a need to increase provider confidence, right? So it's not enough to say, hey, we have the screening tool, go do it, but having an opportunity to learn it together, apply it within a system along with strategies to know what to do differently, really increase the confidence of the providers in this pilot. And people felt more equipped and really benefited from specific training and guidance on these modalities. So the results here are sort of, the implications are that these pilots can really show a need within your organization and agency, right? We don't need to do a multi-site study, but you can do something similar within your organization, just with a small group or one group of providers to show how it's needed sort of across the agency. Other benefits of screening for brain injury, it can support long-term outcomes, right? And so when we're looking at applying for Social Security or SSDI, right? Sometimes a person's mental health or physical health, we know somebody's struggling and that return to work really isn't a possibility right now and that they need this support. But sometimes what we know and what's documented isn't quite enough on its own. But when we add in that positive screen for brain injury, it kind of fills that missing puzzle piece to say, oh, we have these mental health concerns, but we also have this traumatic brain injury. And together that's making it really hard for this person to be well, to be able to focus, to be able to tolerate an 8-hour workday in the same way. I will note that for a person to get SSI or SSDI on a TBI diagnosis alone, they do need to experience both a cognitive and physical impact. So that may require, a more in-depth physical workup by a primary care provider to identify is there physical impacts in addition to cognitive impacts once somebody has screened positive. But the TBI, along with other things that might be happening, may demonstrate the need for SSI, SSDI. Additionally, it can really help the transition into permanent housing for folks who are housing insecure or experiencing homelessness, right? And again, the data isn't so direct to say that a TBI causes homelessness, although we know that about 60% of individuals who are experiencing homelessness had a TBI before they became homeless. So it's certainly part of what's going on there. So if you have a TBI and you haven't had the opportunity to live independently after that point, there may be some supports needed to help with that transition and making it successful. And that opportunity, knowing that the TBI is in existence, helps that happen earlier on to prevent any problems from happening and to make that transition smooth. So it's not to say, oh, you've had a TBI, you can't live independently. What it means is that, we need to assess and identify where the person feels like they need support, where we know that they might need support, and developing these strategies ahead of time. In the case of Derek, right, he needed a little more support to retransition and to be able to do certain things, but he was able to learn all of these skills so well that, it just took a matter of a couple of tries and reorienting to what it was like to be independently housed to be able to do it. Additionally, it's going to support, these screenings are going to support the person being able to access specialty care and referrals and services. So, if somebody sort of has kind of unidentifiable neurological symptoms or chronic pain or difficulties with cognition, making those referrals to providers who can address these. And it's easier if we know that there's a history of brain injury to access these services, but also to identify and kind of give a trajectory of what needs to happen. And finally, connection to brain injury specific services. Most states have a brain injury waiver program or some sort of community support. And so it's worth having this diagnosis to be able to see, are these resources available and is this person eligible for those? It can provide another pathway for people to get the support that they need. Additionally, there may be some peer support networks that can be really, really helpful, brain injury support groups. And it's so validating to be among a group of people who can say, yes, I've had trouble with memory. Yes, I experience these things. Yes, I get frustrated, out in the community, and being able to give each other strategies and can increase that support network that people might need. And finally, again, with a history of brain injury, somebody may be more eligible for things like a supported employment program if that's their goal, to be able to return to work. So now we're going to take things even a little bit bigger, right? So walking through incorporating brain injury into screening, and we're going to go into bigger, like how as an organization do we approach this, and how do we make sure our services are accessible? So I have an overlap here between trauma-informed care and addressing brain injury, because most organizations that are providing care for vulnerable and at-risk populations are going to implement trauma-informed care, and it's a best practice really for a lot of these populations. And sometimes understanding that the trauma-informed framework is really similar to the framework of how we might need to address and be aware of TBI. It's not far-fetched. There really is a lot of overlap between the two. So trauma-informed care understands that there's a high prevalence of trauma. If you're thinking about sort of that TBI at a population level, we understand that there's a high prevalence of head injury and cognitive impairment in my population, right? So we know that both things are there, which means that, trauma-informed care, we're going to assume there's a history of trauma. And with TBI-oriented services, we're going to assume there's a possibility of impacted cognition, and we're going to build our services around that knowledge to avoid re-traumatization. And in the case of brain injury, compensate for cognitive impairment from the get-go, not necessarily needing these individualized care plans for each person, but as an organization, implement these strategies that the person can get to and access them easily. And I think this bottom bullet point is really the key, right? That with trauma-informed care, that we acknowledge that recovery is possible with the right supports. With TBI, we can see that progress and success are possible when the person has the right supports. And people may be stuck or not progressing as much because the right supports have not been made available to them. And that is where, again, that importance of screening comes in, because then we can identify what those right supports might be and have them available so people can move towards their goals. Right. And at the crux of all of this is that we want to be client-centered, and we are going to approach everyone trying to understand that each person has their own individual needs. So how do we identify whether or not we're accommodating for this, right? Some questions to ask yourself in your organization. Are the structured systems we have easy to use? Can an individual easily find the information that they need? Is it easy to find a person to answer a question and provide support, right? We might be able to have all the signage, all the external cueing available, but sometimes we just need a conversation with a person to clarify something or to answer a question. And with everything becoming so automated, of course, some of this is in relation to COVID and not being able to have a lot of people in one space, but just even thinking about being able to get somebody on the phone, right, from a business or a company when you have a question that you need answered can be really hard. We have to go through all these automated systems to get there, when really we just I just need a person to talk to. Another consideration is if our materials meet health literacy and literacy guidelines, right? So if I'm going to provide printed materials for people to read independently or to learn more, are they accessible to different literacy levels? And then finally, I think this one is almost the most important one. What do we do when something isn't working or people are reporting it as difficult or ineffective? So it's fine to identify systems that aren't working, but is there a process to actually change them? And who can bring up those issues? Are we asking staff? Are we asking the people accessing our services? It takes sort of some people who are in the day-to-day, either receiving the services or providing the services. If they're saying this isn't working for folks, we need to think about it, change it, and be ready to address those things. So these are just a few key tips about making a supportive environment. Clear, large signage to point out key instructions and features is really critical. Not just, exit signs for in case of fire or emergency, right? But check in here first. This is where you can sit and wait. These are hours of operation. This is a phone number to call if you need to talk to someone, right? That information should be really available, easy to find, easy to identify. And what you want to avoid is over signage, which is the next one, right? Keeping information organized and in central locations. There's so many places that will post up flyers here and signage there and this, that, and the other. It's visually overstimulating. And it's hard to differentiate out what information might be important. So centralizing some of that information, right? A big bulletin board of like activities, right? And maybe has all the different groups that a person could go to in that one central location instead of having individual flyers scattered out. Same thing about, having a clear list of providers or people available to talk to, and making sure that information is updated, and identifying someone to make sure that information is updated. There's nothing more frustrating than trying to access a service and realizing that it doesn't exist anymore because the information's clear, you have to get in this way. Making sure if there's a change that information is disseminated well. Again, having a staff person readily available to answer questions at a site. And I think the second bullet point again is really important. Do the designated staff to answer questions actually have time to answer questions, right? If you're saying, oh, the folks at the front desk, they're the ones who are there to help clarify information for people. If you're really busy, if your organization's really busy and front desk people are checking people in, or there's more questions than they're able to answer, then they may not be the right person to have available to answer these questions, right? Like maybe you need an information desk person who can just answer some of these questions or give out information on resources or whatever that might be. And across your organization, you want to make sure that staff are aware of the same information and that all messaging is consistent. There's definitely nothing more confusing than getting a different answer from different people in the building. And that's especially disorganizing if you're somebody with any kind of cognitive impairment. And again, providing reminders, right? Do you give out appointment reminders? Do you give out, text messages? Are people in your organization allowed to call and given time to call individuals to help them get to their appointments? Whatever that might be, having that just sort of systematized as part of your organization, again, is going to provide that compensatory strategy to anyone who might need it. Even if the person hasn't been screened or screen positive for brain injury, or, at the beginning, we identified all of these different things impacting cognition, that even if there's not a history of brain injury, some of these compensatory strategies are just really helpful to help people get what they need and get access to their resources. Additionally, if you are going to do screening, right, and move through that, you want to think about who is trained to provide these accommodations, who are the key staff that are going to implement these organizational changes, who's responsible for learning the screening tool and using it, who's going to make sure that information can be input into the system, how is this going to be incorporated into the interdisciplinary care team meetings, and what strategies are we going to try to use as an organization? And again, identifying some people that can really help implement that. You want to have for your staff a systemic way to disseminate this so that, again, things are done in the same way, because that's what's going to help folks the most. And again, a lot of models, especially qualified health centers, are moving in this direction, is, allowing your teams to get together and talk about folks and make a care plan together. And especially for people with cognitive difficulties who need compensatory strategies, having every provider reinforce those strategies can be really, really helpful for the person and is going to be more effective in care and services. And I think too, if you're going to implement these organizational-wide strategies, give your providers and the people who are going to be responsible for doing these things time to get the training that they need to learn and really practice the strategies. Engage the consumers and recipients of services in your organization. Ask them and identify them what's not working, what makes it difficult to access services, and what could be more supportive. They'll probably have some really great ideas, and usually not things that are super complicated or undoable, right? But it doesn't make any sense to go through and develop a whole process and system and changes if we're not totally sure it's going to work for the people who are going to be engaging in those services. You can develop an ad hoc committee, a consumer advisory board, whatever that might be, to really hear this feedback and be prepared to do something about that. The feedback you might hear is that, the first time I walk in this building, I don't want to participate in 10 different screenings with the first provider. And that's fine, right? And that means, okay, maybe brain injury screening can't happen at the first first intake, maybe when they meet with the case manager or when they meet with the mental health provider, maybe at the third visit, it's our goal, right? That's going to help you make these systems more effective. And finally, assess the rigidity of rules and what that might be. And thinking about the people who are not doing well with your services, right? How can we engage them better, and what is making it difficult for them to engage? One of the things I think of most frequently is sort of having time rules to identify somebody as a no-show, right? So if somebody, in a lot of clinics, healthcare facilities especially, if somebody is 10 or 15 minutes late, their appointment is canceled for the day. And this is because things are double booked, or no-shows count against what the provider is billing for during the day. But when we think about, for people impacted by social determinants of health and TBI, all of the different things that can happen and get in the way of getting to that important appointment on time, transportation barriers, getting confused, getting lost, right? We've all had that experience. We're supposed to be somewhere and we can't find where we're supposed to go. All of these things can impact that. And if we consistently are rigidly saying, no, you can't get services here because you're always late, that's probably the person who needs the services more. And so thinking about how can we be flexible, and not frustrate and overwhelm providers, but also make sure that people can get services when they need them. That's one example, but there could be others. And so it's sort of, again, taking that trauma-informed and systems lens to think about, okay, like, what is it that we're doing that's preventing people from engaging with us, and how do we work through that? So I'm not going to go into specifics, but I just wanted to talk a little bit about health literacy, and really the basic guidelines are that any written and printed materials should be at a 6th grade reading level or less, and that sentences should be short and clear. You want to reduce unneeded text. If you're using images, they should emphasize key points, but should not clutter the page. Again, we want to prevent sort of that visual overwhelm and stimulation. AHRQ has an amazing and really robust set of resources to implement health literacy and assess for how you're doing with health literacy within your organization through a toolkit. So if you are thinking about where to start with organizational strategies, health literacy might be a place to start, right? If you can't do everything at once, absolutely understandable. But it's a really valuable training for anybody who might be providing services within your organization. And again, if things are less complicated, if they're meeting a lower literacy level, they're also going to help somebody with cognitive issues and a whole host of other things going on. So it's a really great place to start there. And the link is at the bottom. But if you go to ahrq.gov, you'll be able to find the health literacy toolkits. Similarly, doing training especially for providers on the teach-back method may be another way to implement some organizational change. So the teach-back method focuses on providing education in a way that's understandable and then checking for the person's understanding. So it goes beyond asking yes or no questions, saying, do you understand? Did you get this? Do you know what I'm saying? And is really asking the person, can you show me? Can you repeat back to me what I said? Can you clarify? I want to make sure I taught this correctly. And it's a whole set of strategies and training. So teachbacktraining.org is where you can access a lot more information. Again, if you are not able to do sort of like this intensive cognitive training like was done in the pilot that I mentioned in this presentation, your providers could all do teach-back training, and that would be an amazing system level strategy to make your services more accommodating, because all providers would be checking and making sure people are understanding what they're saying and what's happening within their sessions. And then finally, another resource is the Adopted Clinical Guidelines for Traumatic Brain Injury, developed by the National Healthcare for the Homeless Council. All of these resources that I've just mentioned are available for free, which is another great resource, something that makes them a great resource. But if you're looking at really doing a big systems level and programmatic changes for people experiencing brain injury, this is a great resource that talks through what that looks like in a screening level for brain injury screening for cognition. It gives recommendations for sort of basic and more intensive care, as well as a lot of strategies that can be used. So this is another great resource to kind of dive and guide into all of that. Finally, my last recommendation for systems level strategies is building community partnerships. So oftentimes organizations may exist in silos, and we might know a lot about other organizations that are doing what we're doing or similar work. And we may need to do a little outreach across the aisle a little bit to some of these organizations to help cast that net to catch the people who are falling through the cracks, because they're likely falling through the cracks in many places. And if we're changing our systems in more than one place, we're going to catch the people who need it and be able to connect them to things that are going to help them recover and be more successful. This includes, if you're not connected with, building a relationship with your brain injury association or alliance in your state. They offer resources and support for people with brain injury. You could even reach out to them for staff training. You could collaborate, right? So you could provide training on social determinants of health. They could provide training on brain injury. You could show how your resources meet the needs of their participants and vice versa. Be a really great partnership. And it's especially helpful if you're going to be screening within your organization, because if somebody does screen positively, you can connect them potentially with the resources that are available there. Additionally, some brain injury associations and alliances and states offer waiver programs. And a person, especially somebody who's low income with brain injury, may be able to access some additional supports to help them live within the community and avoid long-term care, especially when that long-term care is not, they could postpone that, right? We want people in the community as long as possible. Additionally, maybe partnerships with hospitals, right? And so this could happen in a couple of ways. Are your hospitals documenting and identifying when people are experiencing homelessness? And so if there's someone who's experiencing homelessness that sustained a brain injury and gets care in the hospital, does the hospital know what to do? Do they know where to refer this person for the right and appropriate support services? Again, engaging with community providers to prevent rehospitalization and engaging more with community supports. We identified that people have a lot of barriers to getting primary and preventative care. And so as an organization that might be providing that, what's the relationship with the hospital? Again, to address these social determinants of health and support people who don't know how to access other services. And again, because we know that brain injury can be a trigger to somebody becoming homeless, most likely these people are living in poverty or sort of like in the margins when the brain injury occurs. And they no longer can return to work, they lose their income, become homeless. So what's the hospital's role in doing that? Can they identify when that might be somebody's situation? And can we connect them with services early to prevent that experience of homelessness? If they've been treated in the hospital emergency room for a brain injury, who can come in and wrap around and help coordinate care so that the person doesn't lose everything? Again, connecting to outpatient rehabilitation programs, referring people once you've screened somebody positive for brain injury, connecting them because they may never have gotten these services, like Derek in our case study, right? Like because of the circumstances around his TBI, he never got speech therapy, he never got occupational therapy or physical therapy, and really could have benefited and did benefit from it when he could access it. Similarly, again, that cross education, if you work with some of these populations and you're really good at addressing social determinants of health, perhaps that outpatient rehabilitation program needs some of that education. Can we build a partnership around making their services more accessible for individuals? Again, depending on the state and insurance status of the people you work with, some of those outpatient rehabilitation services just may not be accessible. But that doesn't mean you can't get those services. So that might be building some relationships with medical and allied health professional programs, right? Are there ways to engage students and their professors, right? So, experienced clinicians to be able to supervise some student programming to help do some of the services that might be needed, such as providing assessments, even doing an environmental evaluation of your space and making recommendations for accessibility, running support groups, all of these services that can happen that can benefit the students certainly, but can also benefit the clients because now they have access to these services. And additionally, finding out what consumer groups are available in your community. If you run consumer groups, but there may be other peer support groups for people who've experienced a brain injury, and that might be the right place for the person to connect. And that peer support can be really helpful and critical. Again, engaging with substance use and recovery programs, as noted in the pilot program I spoke about earlier, there was a really high number of people who'd had a history of brain injury who also had a substance use diagnosis. And so again, this cross training can occur for programs that address social determinants of health. How do we train these recovery programs and then also engaging brain injury providers? I've been in a few different recovery programs, and sometimes because of the nature of recovery programs, the rigidity of the rules can be really, really difficult for people to engage in those programs. You know, you have to come on time, you can't miss anything, you can't take breaks. You know, it's hard for people to focus and pay attention. They're not always housed in the nicest buildings that are, you know, really well decorated, right? The environment's not stimulating. And so sometimes there needs to be a level of education. That collaboration really helps everyone's goal of the person being successful and can be really critical. And again, if you're on the other end, if you're more kind of in the brain injury world, cross over and engage with partnerships and community programs to address social determinants of health. And maybe you are one of those programs. And then the key really is like, build those relationships in your community. Not one program has to do everything. You know, building in partnerships is wonderful. You just want the pathway to these programs to be clear and easy for people to access. So not just like, oh, just here's the phone number for the food bank, call them, but like, can the food bank bring food to your organization for you to distribute out to the people that are there? And making it really, really easy to get these services. And that's gonna help people be more successful. And finally, advocacy. It may take identifying gaps in services, you know, and we know that there are significant gaps in communities. People who are living in poverty have a harder time getting health services. It's hard for them to access good long-term care. We know that there are gaps, certainly, for people who can't necessarily live independently, but we don't want them to be institutionalized. And sort of those interim, you know, assisted living, supportive housing environments are not always available, especially for people without income or with low income. And, you know, I don't have an answer for all of that, but I think if you're bringing all these community groups together and collaborating and developing services, you can find some answers to that. And it's really going to be on the community to do that and embrace that and say, you know, there's a group of people who aren't doing well and we want to serve them and we want to address them. And using any positive outcomes and case examples really to highlight successes. It doesn't have to be 100, it can be 5, right? But individual stories can be really, really meaningful, demonstrate the need for change and really the success and outcomes that can happen from everything. So a lot of information again. I hope that you were able to learn something or this sort of generated some thought for you about how you can approach this. Not just at an individual level, but sort of at a larger level. But I am more than happy to take questions and look forward to talking about this more. And before we run to questions here, I'm just going to acknowledge my references for all the information presented today. So thank you again for joining and look forward to questions.
Wow, Caitlin.
Hi, everyone. Welcome to today's session on systems level.
There we go. Thank you so much. So we had a couple of questions come up in the Q&A. If maybe you want to go over a little bit of the brain fog question. So in your opinion, if the state of the art comprehensive treatment for brain fog, if you want to go over that just a little bit.
Sure, yeah. And I would say that there's probably not a quick and easy answer, and it is dependent on the cause of the brain fog. So like specifically to the brain fog that people are experiencing after having been ill with COVID, certainly they're developing what that treatment should look like since that's so new. But I think part of it boils down to what is causing the brain fog for an individual. So if it's, you know, it's important to maybe do a medical exam and rule out if there's something more major happening neurologically or cognitively. But if that brain fog is a result of sort of that chronic stress or trauma, you know, sort of speaking to everyone's experience with brain fog from living in COVID. It might be more connecting with mental health services to address what's going on there. And so it could be a multifaceted approach. And certainly in some cases, it might be more about self-regulation and developing skills to increase alertness, to be able to focus. So I think it's really dependent on cause. And again, if it's from a lack of resources, whether it be housing or food and nutrition, it might be addressing that first. So that the person, if you're well fed, you are more likely to focus, and that can clear some of that. And certainly people who are lacking in certain nutrition and vitamins and that type of thing can experience more brain fog as well. So it really sort of depends on the cause there.
Wonderful. That makes a lot of sense. And there definitely were quite a few questions about different screening tools that might be available out there and who might be able to use them. So if you might want to talk about the OSU TBI a little bit and who can use that.
Sure, yeah, a huge advocate for the OSU TBI ID. Part of the reason is that it's a validated instrument for a lot of these populations discussed in today in the previous webinar, people who have been incarcerated and experiencing homelessness. So there's not a lot of tools out there that are developed specifically with these populations. So that's one of the reasons I like it. And as a clinician, I really like it because it's not super difficult to administer and doesn't take a ton of time always. Certainly if somebody has a longer history, it can take more time, but a lot of levels of individuals can complete this screening. So it doesn't require it to be done by a medical provider, a diagnosing provider, an intake person, a case manager, whoever might be answering some of these questions and asking some of these questions at intake anyways, can do that. The next piece of the process really is that if there's a positive screen, it's important to connect the person with another provider that might be able to make the diagnosis or do more of a formal workup to determine what's going on with folks. There's certainly other screening tools, but that's the one that I have the most experience with using, and a lot of states have actually started adopting it as they're adopting more comprehensive screening processes for brain injury.
Wonderful, thank you. Another thing that you brought up quite a bit in your presentation is kind of organizations' ability to take on different amounts of this and kind of how to ease into that or understand what your capacity is. Could you talk a little bit about the importance of having a champion within the organization, or kind of how to get into an organization if this is something that you want to help out with?
Yeah, absolutely. I think sometimes it's speaking to and aligning with what is the mission and what are the outcomes, the intended outcomes of the organization, and how does screening support that? I know it's easy to over-screen people, and providers will say, I don't want to spend the first 4 times I'm meeting with someone doing screening tools. Like, I actually want to get to helping them. And so it is a little bit of a balance of figuring out when is the right time and right place to administer these screenings. But I think always identifying, if we know that this is going on with a person, then we're better able to support them and connect them with resources, which is going to help us do what we need to do. So viewing it more as a tool to improve outcomes, as opposed to sort of this burden of like, oh, here's one more thing, one more checkbox that I have to do. And I think acknowledging that sometimes, and that's where maybe there needs to be a little creativity in who's administering it and when, especially starting out. Like, it's, likely not realistic to say everyone in the organization is going to do this. So thinking of who might be the best sort of smaller group to start with, and seeing where that need puts you in your organization. But I think highlighting just some of the data and evidence can be really supportive when we know it's so prevalent in a lot of these populations and so under-identified. And thinking about some of your clients in your organization that you're like, this person isn't doing as well as others. Is this why? Is this, if we figure out how to work with them better, could we improve that?
Wonderful. And another thing that got brought up was in these organizations, there's oftentimes like an overload of work, and that there tends to be a lot of high turnover in staff. Do you have any ideas about how to manage screening programs and accommodation programs with high turnover?
Sure, yeah, I think part of it, and sorry, of course there's a really large truck driving by as soon as I'm talking. But part of it, I think, is doing a training to to address needs with brain injury shouldn't just happen once in an organization, even if you don't have high staff turnover, because it's complicated and new things are going to come up and clients are going to bring up new concerns. And none of us are ever experts after doing one training. And so I think part of it is just if there's a routine practice, and so that helps people who are newly coming on board become oriented and aware of this information, but also gives other folks a chance to bring up new things or sort of refresh your memory about these things. I think just making sure it's an ongoing conversation, as opposed to like, we're going to offer this training one time and then that's it and everybody's going to take it and run, can be really helpful. And then with screening, I think the more incorporated it is into your program's processes, the more likely it is to stick, even if you have high turnover, so that it's just something that anybody in this role does, and there hopefully will be people experienced willing to help the people who are newer in implementing it. But it just, yeah, it shouldn't be something that lives with the staff that are there now, but how does it really get integrated in what we do as an organization? And that'll look different depending on each place, but is an important thought to consider when looking at implementing screening and accommodations.
Yeah, that's such a great point of, it becoming a part of the institution rather than just the staff. And having those repeated trainings, I think, could really give, staff a great opportunity to provide those success stories that I learned this, and this is kind of what happened for me and how I was able to help my clients better. Seems like a really great opportunity. Well, I think that was all of the questions. I want to thank you so much for sticking around a little bit past the hour. And I just want to let everyone know that the recording will be available this Friday. It will be emailed out to all registrants, and there'll be a short evaluation form along with that. And that at the end of the evaluation form will be a certificate of completion for you to download. And if you have any questions, please feel free to email me. I'll put my email back in the chat real quick. And thank you, everyone. Have a wonderful day. Bye.